Well, we're really excited to have our very own Gracie Champion, who's a registered dietitian, as our guest didactic speaker. She is an inpatient and oncology palliative care dietitian, and she's going to be presenting today on dietary perspectives of anorexia and cachexia. So we're so happy to have her here. If you have any questions, write them down, because at the end of her presentation, we'll have an opportunity to ask them right after her presentation. So I'm going to turn things over to Gracie, and again, thank you for being here, Gracie.
Yep. All right. Well, thank you, Chris, for the introduction. All right. So for my first slide, I have one of my favorite quotes as a dietitian, which is, "Food is comfort, food is energy, food is life." And the reason that I have that here is I think it's really important, before we jump into a lot of talk about numbers and criteria and diagnosis, to really remember at the end of the day how important food is to us and to our patients. You know, food is one thing that we all have in common. People across different cultures, different countries, different diagnoses, everybody has to eat. It may take different forms in different people, but we all have to eat, we all have to have food, and so it's something that we can all share. As a dietitian, one thing that I try to be really careful about is to avoid over-medicalizing food. We may, especially when I talk to patients. On the dietitian side and the side of health providers, we have some requirements to talk about things more in ranges or numbers, but when talking to patients, it can take takes a lot of the joy away from food and really put some undue stress on it when we really focus heavily on things like numbers, and you need to get this number of calories in a day. So anyway, we can talk a little bit more about that later, but just wanted to remember that at the beginning of the presentation. So the objectives today are to learn about what anorexia is, what cachexia is, understand some of the differences between the two, as well as address some of the reversible causes of anorexia. And then at the end of the presentation, we'll talk about what happens in the situation where there really is nothing more that we can do from a nutritional perspective. So one question that I get asked about often is why? So for an example situation, I may be up on the floor in the hospital about to go see a patient who may be on comfort care or who may have a terminal illness, and I've heard many times from different providers and different folks, why are you going to see this patient? Aren't they on comfort care? Why don't they just eat whatever they want? Maybe from family members, is this too late? And the reason that we care so much about nutrition and why we will try to still make a nutrition intervention even in the end-of-life scenario is because nutrition can have an impact on a lot of different factors for people across the life cycle, including people who are at the end of their life. Nutrition can impact folks' body image. That's a really important one, especially for people who may have a disease or a condition that you can't see on the outside. You know, they may not have like a visible tumor or something that's really visible. And so to the patient and to their family, when you start to see changes in their body composition, especially dramatic weight loss, that's often when it's a red flag, and it's really concerning to patients and family that, hey, something is wrong. And often changes in body composition is what brings people to nutrition, or brings people to medical attention in the first place. I can't tell you how many charts I've read where the patient came to the doctor because they had a 50-pound weight loss. Fluid status is really important. When people, at all stages of illness, people can become fluid overloaded, they can have dehydration. Nutrition status can impact whether people have the ability to heal different wounds, which is something we'll talk about in our case today. It can impact their ability to resist infection, pressure ulcers, energy level, their relationship to caregivers, which is really important because with nutrition, this is often one of the last things that people can control. They may have medications on a schedule, which whether they follow that remains to be seen, but whether they eat, what they eat, when they eat is one of the last things that is really up to a lot of people, and so it can put some pressure on their relationship with their caregivers when they don't want to eat and the family member wants them to eat, and it can definitely cause some stress. And then finally, bowel function. When somebody has diarrhea or has constipation, that can really affect how much they. So decreased food intake towards the end of life is very common. It's something that we see in a lot of patients who have oncology diagnoses as well as other medical conditions. And it's often related to anorexia and cachexia. It may be related to a physical obstruction, to weakness, and to poor appetite. So how common are nutrition issues at the end of life? There was a study that was done by a palliative care team at a hospital, and I believe that H is for Hong Kong, back in 2006, where they surveyed a ward of folks who were getting palliative care, and they found that weakness, anorexia, and pain were very common in most of patients, and then 50 to 65% of patients had issues with dysphagia and weight loss as well. So if you only take one thing away from my presentation today, the thing that I want you to remember is how important timing is with nutrition, and knowing that it's really hard to have set criteria or set ranges because each individual patient is going to be so unique. And so what is appropriate for one patient for nutrition may not be appropriate for another. And what is an appropriate nutrition intervention at the time of disease diagnosis may change as they approach the end of their life. I really liked this Nutrition Now campaign from the United Kingdom Royal College of Nursing that says that it's important to ensure that patients have the right type of nutrition and hydration at the right time. And we'll talk a little bit more about that with our case today. So do nutrition interventions work? That is always the question. When somebody has limited time and we have limited resources, it's really important to make sure that the things that we're suggesting do bring a benefit to the patient. A colorectal cancer study looked at nutrition interventions in the form of dietary counseling. So they had all the patients see a dietitian, and then they supplemented their diet with a protein shake. And they found that nutrition status, energy intake, and quality of life were improved. There was also a study that looked at patients with unresectable pancreatic cancer that found an association between weight stabilization, longer survival, and a higher quality of life. One thing that I think is important to look at with these studies is two things. One is the N, so these are both pretty small studies, and also is knowing what interventions they used. So in these cases, it was protein supplements, which would be something like Ensure or Boost, and nutrition counseling. So these studies, that you can't necessarily project this information out to include some of the more aggressive nutrition interventions that we'll talk about at the end of my presentation today. Next slide, please. So Chris suggested I make a good joke about this slide. I think my Mac didn't communicate super well with ANTHC's PCs. And if I was sharper, I would have a joke about how this blank slide is a great example of anorexia. But what I wanted to talk about on this slide is just to really start to establish the difference between anorexia and cachexia. It's so important to define the terms that we use. And I think that can apply to both healthcare providers and in our communication to families. So anorexia is kind of a complex syndrome that's contributed to by poor appetite, decreased intake, typically weight loss, and it's usually where patients just don't feel as hungry. And it's a symptom that is really common in people who are undergoing cancer treatment. And one of the reasons why I think it's so important to define our terms is because here in the hospital setting, we use this term a lot. It's like a fancy word in the chart to use often for poor appetite. But when we're talking to patients and families, most people out there have only heard this term in connection with an eating disorder. And so it's important when you're talking to families to say, either say poor appetite or say what you mean, because I have run into the situation in my own practice where somebody gets a weird look on their face when I'm talking about their symptoms and they think I'm talking about an eating disorder. And really, having a poor appetite may be some type of disordered eating, but people just have a different connotation with that word. And so, actually, can you go back again? I think I lost a couple slides. So I had a really great table that went into a lot of the different symptoms that are associated with anorexia. And one of the great things about anorexia, or a positive way to look at it, is that it can be really addressable. If we really try to fine-tune what symptoms are contributing to the anorexia, and then addressing each of them individually, it's something that can be improved. And so luckily I see these a lot, and so I think I can hit on most of the big ones. So one of the first things that contributes to anorexia is nausea. And a lot of the symptoms I'll talk about today do have many pharmacological and medical interventions, but today with this talk on nutrition, I'm just going to touch on the nutrition intervention. So with nausea, some of the really important things to do are to address smell. So our smell is really closely attached to the nausea and can often be a trigger for patients. So some things to do include trying to avoid really stuffy rooms. So if somebody has windows that open, making sure they have a source of fresh air, making sure that well-meaning friends, family, and visitors don't have really strong smells. Something you may think smells great can be a huge trigger to somebody else. So trying to avoid perfumes and scents. And then cooking odors is a big one. And this is hard because if you want to eat, often you have to cook, and to cook you have to make some food smells. And so this is, I think, is actually a really fun opportunity to give something to friends and family to do. Many of my patients have nausea that's triggered by smells. They also have fatigue, and they also have this big group of family and friends that is desperate for something to do to help. And so I'll often suggest for some of the heavy cooking of things like, say, a casserole or a lasagna or spaghetti that's going to be a big thing to cook, have somebody else make it for you. You know, that person who's desperately looking for something they can do to help, give them a recipe, give them a meal idea, and that way they can make something outside the home, and then you can bring it in and throw it in the freezer and have less of a smell if, you know, if you're not cutting up the onions or if you're not cutting up a lot of garlic. And then some of those foods may also be eaten cold, which may seem unappetizing to us, but anytime you heat something up, it's going to have a lot more of a smell. And we do have to be careful with this respect to food safety, and so making sure that if we do have food that we're not heating up, that it's been in the fridge for an appropriate amount of time and whatnot. But the gist of that is to try to avoid the cooking smells as much as possible. In terms of other food interventions for poor appetite, often people have trouble swallowing, which is dysphagia, or odynophagia, which is pain with swallowing. And so somebody may actually want to eat, but it's painful or it's difficult, and so they're avoiding eating, and it's contributing to this snowball of symptoms. And so with both of those, one of the best interventions I have is to make sure that their food is really soft and moist. It makes it much easier to swallow. And then trying to avoid foods that are really spicy, really sweet, really have sharp edges, anything that can kind of exacerbate that really tender tissue in their throat. The symptoms of odynophagia and dysphagia can happen with a lot of different conditions, but I find those most commonly in patients who are undergoing radiation to the head and neck area. Another symptom to address in terms of anorexia is dry mouth. And with this one, luckily there's a lot of things we can do to help. One of the things is to refer the patient to their pharmacist or to the medical team to see if there's any medications that can be modified that have dry mouth as a symptom. But in terms of food, chewing sugar-free gum and sucking on hard candies can help to stimulate saliva. You can have the patient try to make sure they're well hydrated and then carry around a water bottle so that they can wet their whistle frequently. And then making sure your patient has chopsticks so they can help with dry lips. And sucking on things like popsicles can really help with dry mouth. Two symptoms that kind of go together hand in hand are constipation and diarrhea. And so for constipation, in terms of food interventions, I always like to do a quick food recall to find out what people are eating and to see if we can address fiber. And it really does depend on the stage of their treatment they're at. Some folks get frustrated when I ask them about fiber because they're really not eating anything at all. And so you have to kind of feel out where they're at. But if somebody is at the stage where they can modify what they're eating, trying to encourage some soft fruits and vegetables that still have a little bit of skin on them. Oftentimes for people, something like an apple is going to be too hard, but maybe cooked apples that have the skin on them will help with the fiber. Other fruits and veggies where they can handle it. And then some people it's more appropriate to add a fiber supplement. With diarrhea, looking for hyperosmolaric drinks is a big one. So if somebody's drinking a lot of Gatorade or a lot of juice with a lot of sugar, sometimes that can cause diarrhea. Another one is looking at lactose. So many people are lactose intolerant, especially elders and especially Alaska Native people. It's just a little bit more common. And this isn't quite as fast of an intervention because most people at this point know if they're lactose intolerant, and usually they're avoiding those foods. But sometimes we can identify triggers that they didn't realize had milk in them. And then it's kind of funny on the other end of things, I have a lot of folks that when I ask them if they are lactose intolerant, they say yes, but they still use milk to help address their constipation. So people will actually be using milk products to induce a little bit of diarrhea when they're having constipation. So I think I touched on most of the main nutrition interventions and symptoms. I'll probably think of some randomly there. Okay, next slide. All right, so let's talk about what is cancer cachexia. So with anorexia, we were looking at more of a constellation of symptoms that can be reversed. And with cancer cachexia, we see this when patients have an ongoing loss of skeletal muscle mass that can't be fully reversed by conventional nutrition support, and that leads to progressive functional impairment. So cancer cachexia is something that's tricky. It's really hard to know when to diagnose it and to know when all of the appropriate interventions have been made. And part of the reason for that is because we don't really know exactly what causes it. And so it seems to be a paraneoplastic syndrome where people are metabolizing their protein and the other breakdown components of their food differently in the setting of a terminal and advanced cancer. And so it's typically characterized by declining weight and physical function. And it's important to know that cancer cachexia affects not only patients but also their families. One thing I mentioned earlier in this talk is how difficult it can be for families and for patients when their outward appearance starts to manifest what's going on inside their body. And it can be incredibly distressing for caregivers who often feel that their role is to feed mom or dad or to feed grandma or grandpa or their child, and that they can take it as a failure when, despite their best efforts and despite, in some cases, a lot of calories, people continue to lose weight. So cachexia, as I mentioned before, can be caused by abnormal metabolism, skeletal muscle atrophy, and this is where when you look at a patient, you may see protruding clavicle, a scaphoid abdomen, really thin upper and lower extremities. You may be able to count their ribs. And then you'll also see a loss of subcutaneous body fat, and that's where people have loose skin and you can tell that their body form used to be different. So some of the secondary nutrition symptoms that are related to the reduced food intake include early satiety, so feeling full really easily, nausea, shortness of breath, dysgeusia, where food doesn't taste the same, pain, constipation, and depression. And cancer cachexia can be pretty common, especially in advanced serious illness, anywhere between the range of 24 to 80% in some studies, depending on the diagnosis. So we talk about the cachexia diagnosis, and typically it goes across a spectrum. Pre-cancer diagnosis or pre-whatever serious illness diagnosis, somebody may have a normal nutrition status. They may be overweight, underweight. And then pre-cachexia is before somebody gets to the point where their symptoms can't be reversed. And typically that's more where we're seeing people who have anorexia. And then refractory cachexia is where a patient is unable to gain weight and to gain muscle mass despite adequate calories. And typically we see refractory cachexia in somebody who is near to the end of their life. And so some of the symptoms that are used for diagnosis include decreased muscle strength, reduced muscle mass, fatigue, anorexia, and biochemical alterations like anemia and inflammation. So you may be wondering, why did she put this weird picture here? And the reason I put it is because I think although it can be a really difficult conversation, sometimes it can be incredibly freeing for patients and their families when we acknowledge that this is going to happen and there's not a lot you can do about it. because you take away that pressure from eating where we have to keep pushing more Ensure. You need 8 Ensure, 10 Ensure a day, or we need to keep pushing these different foods or increasing calories. And when you take away that pressure that says there's always one more thing we can do, it allows people to relax and enjoy eating, and give permission that it's okay if you don't want to eat. It's okay if your family member doesn't want to eat. This is something that we expect at the end of life. I think it can take a huge burden off of patients and families. And a few other points on this slide are to note that somebody can have malnutrition with a wide range of BMI. And so we'll have patients who may not be eating anything at all for a long period of time, but because they were obese before diagnosis, they may not necessarily have that expected physical appearance. Next slide, please. So let's talk about goals of nutrition. So if possible, stabilize the patient's weight, so stop a dramatic trend of weight loss, and maintain lean body mass, improve their energy and protein intake to help reduce the treatment toxicity, and to help improve the patient's quality of life and performance status. And so basically, in a nutshell, across this continuum of serious illness, while somebody still has the opportunity of being a candidate for further treatment, we don't want nutrition to be the thing that stops them, but we want them to feel as well as possible. So let's talk a little bit about nutrition support. This is something I've been dancing around a little bit at the beginning of the presentation, talking about interventions like dietary counseling and protein supplements. So oral nutrition supplements are things like Ensure and Boost, some homemade recipes that are concentrated sources of calories and proteins that people use orally. Enteral nutrition or tube feeds is when somebody has a tube that bypasses the volitional part of intake, where somebody's deciding to eat or engaging in the act of eating. Somebody may have a Dobhoff tube, which it goes in through the nose and ends up in the stomach or the small intestine. Or in the cases where somebody's GI tract isn't working anymore, they may get their nutrition directly into their bloodstream through an IV. So this gets down a little bit into the weeds with nutrition, but I think it's so important to share this information so that we are fully informed before we make promises to our patients about what is going to be covered for nutrition. And so there's 3 main categories for patients, typically. Patients who have Medicare, patients who have Medicaid, and patients who have either private insurance and or IHS. And typically the patients we see here at the Native Hospital have IHS as well as one of these 3 categories. And so Medicare will only cover nutrition if it's the sole source of nutrition. And typically that means it's going to be going in through an IV or through a tube. And so for many of our patients who physically can eat, Medicare will not cover any nutrition supplements. And typically using the word supplement is something that is a clue that it won't be covered, because it has to be their sole source. So when you have patients who are eating a little bit but not enough and they need some Ensure to help make up that difference, that will not be covered by Medicare. The reason for nutrition support has to be really well documented by the doctor and the dietitian, as well as the speech language therapist if they're consulting. Some examples of patients who do qualify for coverage typically through Medicare include people who have a physical blockage. So somebody who cannot swallow anything because, say, their esophagus is blocked. Medicaid, on the other hand, is a little bit easier to get supplementary nutrition. And so typically, as long as you have good supporting evidence for why a patient can't meet their nutrient needs, Medicaid will cover oral nutrition supplements like Ensure, or they'll also cover tube feeds when they're indicated. And then private Ensure, who knows? This is kind of a wild west of nutrition coverage, and it really varies by the company. I think it's safe to typically assume that private insurance will follow Medicare guidelines. And so most private insurance companies will only cover nutrition if it's the patient's sole source of nutrition. And then finally, really important to know is that IHS does not cover any durable medical equipment or nutrition supplements outside of inpatient admission. And so some people assume that IHS will cover everything or anything, but unfortunately they don't. And that can be really disheartening to patients when they're promised something or they expect something and then find that that's not the case. And so what that means is when somebody's in the hospital, we will feed them whatever way is indicated medically. So if they're on a diet, their meal trays are provided. If they're on tube feeds, that's provided. But once they go home, whether it's Anchorage or a rural village, the ANMC cannot provide their nutrition. So we can't send tube feeds or insure out. And so finally, talking about some interventions and just a few final points to keep in mind is that the diet and health may be different from the diet and illness. I think that's something really important to keep in mind, and that we have to adjust our expectations. So where you have say you have this stereotypical patient who eats meat and potatoes every day, 3 meals a day, when they feel well, during their cancer treatment, they may do much better with really small meals and snacks and having food spaced throughout the day. And they may do better if their food is minced up smaller and served with some extra moisture. For maybe the more stereotypical diet, we're pushing dairy products as a good source of calcium. But knowing that during illness and during cancer treatment, that if dairy is tolerated, awesome. It's a high source of calories. Add cheese, butter to everything. Recognizing that lactose intolerance is really common, especially in advanced age, certain ethnic groups, after radiation, after complex antibiotic treatment, and in some GI infections. And so you may need to stay away from dairy during this time period. And then finally, our oral nutrition supplements considered artificial nutrition. This is something I like to touch on in all talks just to help spread the information. I think one of the reasons that it's confusing is because occasionally we do use something like Ensure or Boost that is an oral nutrition supplement as a tube feed. And usually those are in the situations where a patient may not have insurance coverage for a dedicated tube feeding formula. And so say somebody gets a feeding tube and they're just on their own, we may send their family to Costco to buy Ensure and they'll put that through the tube. And so in that case, it would be considered artificial nutrition. But when somebody's using something, a protein shake by mouth, and they're drinking it, then it is not considered artificial nutrition. It's basically like medical food. And so it's high protein, high calorie food. But if somebody has an advanced directive, again, it's always important to clarify what their wishes are, but if they have checked that they don't want artificial nutrition and hydration, formally that means when the volitional part of intake is bypassed and somebody's being fed via a tube or an IV, and knowing that nutrition supplements are really, for many oncology patients, an important way of meeting their nutrition needs, even if they don't want more aggressive nutrition support. I think that might be the last one. Oh, one more slide. So this slide talks about the complexities of nutrition support in rural Alaska. So recognizing that when we send patients home with nutrition support, it's so important to touch base with their PCP or with their local health aide, because it may not be as straightforward to do something like tube feeds in a small village that may have unpredictable air access. The patient may or may not have running water. So just trying to make sure we're addressing those things ahead of time to help save a headache of a patient getting home and then not having the supplies that they need. Alrighty, I think that's the last slide. Does anybody have questions?
For the group, we have about 5 minutes for questions. So if you have comments or questions for Tracy, we'd love to hear them. And just know that there is a group chat. So if you're having a hard time getting through, you can also send a message with a question as well. It looks like Rana is waving her hand over there at ANMC.
Hi, I did have a question, Gracie, and this might be a silly question, but I was wondering for especially for cancer like pancreas cancer, that a lot of times they get that spike in blood sugar towards the end, but they also get really anorexic. What are some suggestions for I don't know, do you have any ideas about how to manage that, or what do you typically say to patients?
Man, that's a hard question. Off the top of my head, what I'm assuming is happening, because it may be perplexing where somebody's not eating, but they have high blood sugar, And so I'm guessing it's probably related to endocrine dysfunction, and also knowing that people can store glucose in their liver in the form of glycogen and access that when they're not eating. So even though they aren't eating their food, their body may be releasing some glucose, as well as their pancreas not reacting to it as well as it normally would. But you know, that's a tough question, because when somebody's not eating, we can't employ our traditional techniques of carbohydrate control. And I'm sure you've probably been in a situation of trying to talk to somebody about carb control who's not eating. And there's really nothing more frustrating for the patient. And so I think, man, I don't know, this might be a good question for Chris, because I would, you know, look at things like what are we doing with their insulin, but then you also worry about safety in somebody who has high blood sugar and you're using insulin, but then they're also not eating. So the short answer is I don't know.
Yeah, and Sean, you might have something too, but again, it comes down to the basal, insulin, and so thinking about your long-acting, like glargine, can be really helpful to bring that down. And again, especially when you're talking about end-of-life care, because this just came up with a patient last week. We were talking about, someone on a steroid who it's just going to elevate their blood sugars, and it's really about symptoms. And so, when you're getting the higher levels of 400, 500, you can get really symptomatic. And so that's where a long-acting like glargine can be helpful, because you don't have to be super strict in getting them at goal, but it's about getting them to a level where they don't have symptoms. Do you have other things to add, Sean?
No, I think that's exactly right. It's just a more tolerant approach, avoiding the lows and the really serious side effects of hypoglycemia. But I think it's in the past been underappreciated how symptomatic end-of-life care patients can be with hyperglycemia, severe hyperglycemia. So it's worth it. And I listened to this big debate between hospice professionals about this, and they felt like, no, it can make a real big difference, especially if you have, weeks to live, for example, as opposed to just a couple of days.
Thank you. That was helpful.
Any other questions, Sean?
I think the hardest thing for me, inpatient, where we have a lot of patients who struggle with some malnutrition, they definitely have anorexia, often from their cancer, and we're trying to understand the reversibility of their decline in functional status. And it's a combination of hospital-acquired disability, general deconditioning, but also their nutritional status and the loss of lean body mass. And the family's general disposition is usually, okay, we're improving from the acute process that brought us to the hospital. We just got to keep getting stronger. We just got to keep getting better. And we got, a lot of our patients actually really look forward to going home and having their traditional foods. And I really believe there's a lot to that. But I also want to appropriately counsel about the potential that patients have and the life-changing loss in functional status that may not be reversible. And it's a point of counseling that I struggle with. I generally cast doubt and share my worries that we may not get back to that point. But I wonder how you navigate how much is the nutrition piece versus a loss of lean body mass and the hospital piece, which the hospital piece may actually be more reversible as opposed to a persistent issue. And I don't know, when you talk with patients, how you mitigate that hope and reframe it to what's something a little bit more realistic.
Definitely, I agree. It's really hard, and it's one of those things I think it's easy to say, for me to say in this presentation, that you get to this point where it can't be reversed, and then it's so enlightening when all of a sudden you acknowledge that it's not going to get better and you just eat what you want. But the reality of that conversation goes differently with every patient. And some people really appreciate having somebody say that, and because they may have been feeling it for a long time, and their family member just keeps pushing them to eat. And I think, to me as a dietitian, that's the thing I really want to try to address, is that relationship between the caregiver pushing the patient to eat and the patient trying to eat and feeling like they're failing, and to try to help take some stress off that situation. But I agree with you. I think it's especially hard. I typically have this conversation in the clinic with my patients because in the hospital there's so many unknown factors. We don't know how much the fact that the patient doesn't like the food or they don't like their roommate or whatever situation is affecting what they're eating, and then we don't know what's going to happen when they go home.
Yeah, that makes sense. Like not doing a sleep study until you're in the outpatient setting, you know.
Definitely.
More real life.
Well, I just appreciate you, Gracie, sharing your wisdom with us. And just know that if you have questions, you can always email us and we can get those to Gracie. And she's a really great resource. Our palliative care phone number is 729-1112. And we can help guide you, to get to Gracie if you do have questions.